This is an example of an occiput anterior and well-flexed position. The chin is close to the fetal chest, and the posterior fontanelle is palpable during a vaginal examination. This is an example of an occiput posterior and deflexed position. The chin is away from the chest, and the anterior fontanelle is palpable during a vaginal examination.
Descent of the fetal head often begins before the onset of labor. Throughout the first stage of labor, the contraction and retraction of the uterine muscles allows less room in the uterus, exerting pressure on the fetus to descend further. Flexion increases throughout labor. The fetal spine is attached near the posterior part of the skull. Thus, pressure exerted down the fetal axis will be more forcibly transmitted to the occiput than the sinciput, making the occiput the leading part. During a contraction, the leading part is pushed downwards onto the pelvic floor muscles. As the contraction fades, the pressure against the pelvic floor lessens, and the muscles rebound, causing the occiput to glide forwards. It is the resistance against these muscles that causes the rotation of the head. The slope of the pelvic floor determines the direction of rotation. The widest part of the head is now in the widest part of the pelvic outlet. The occiput can now slip beneath the subpubic arch, and crowning can occur. Once crowned, the fetal head extends and the subocciput region pivots around the pubic bone. The head is born by extension as the face appears at the perineum. A slight untwisting movement now corrects the twist in the neck from the fetus, which resulted from internal rotation of head. The occiput moves 1/8 of a circle towards the side from which it started. The shoulders undergo a similar rotation to that of the head to lie in the widest diameter of the pelvic outlet, namely anterior-posterior. The anterior shoulder is the first to reach the levator ani muscle, and it therefore rotates anteriorly to lie under the symphysis pubis. Because this movement follows the same direction as restitution, the occiput of the fetal head now lies laterally. The shoulders are usually born sequentially. The anterior shoulder is usually born first by slipping beneath the subpubic arch, and the posterior shoulder passes over the perineum. The separate birth of each shoulder will enable a small diameter to distend the vaginal orifice, as well as avoiding overstretching of the perineum.
Descent, flexion, internal rotation of the head, extension of the head, restitution, internal rotation of the shoulders, lateral flexion.
This is an example of an LOT baby. When the biparietal diameter of the fetal head is parallel to the planes of the pelvis, the head is in synclitism. The sagittal suture is midway between the front and the back of the pelvis. When this relationship does not occur, the head is said to be in asynclitism. Here are examples of LOT asynclitic positions. So first we'll show posterior asynclitic. This is when the sagittal suture is closer to the symphysis pubis, and the more prominent parietal bone is the posterior parietal bone. Then we have anterior asynclitic. That is when the sagittal suture is closer to the sacrum, and the more prominent parietal bone is the anterior bone.
If the baby has been in a posterior position descending into the pelvis with a slightly deflexed head, the pressure exerted on the cervix can be uneven, resulting in an anterior cervical lip. Before applying pressure on the cervical lip, some things that you can do are changing position, applying ice, encouraging the client to wait and breathe through contractions, and when this is not possible, you can put 2 fingers on the cervical lip and, in conjunction with maternal effort during a contraction, push the lip over the baby's head.